This is a case of fixator-assisted femoral deformity correction that I want to share with you. You can see this is the long leg alignment of a man in his 30s. He has broken his left femur many years ago, and you can clearly see that this has healed with an element of deformity. There is both a rotational as well as an angular deformity, and the angular deformity is in multiple places in the shaft, and I'll come to tell you exactly where those are. So the mechanism by which we correct this deformity is by surgically dividing the bone with a process called an osteotomy, and then performing internal fixation by form of an intramedullary nail, which is inserted inside the femur to then correct the shape. And during the operation, we use an external fixator in order to assist with holding the limb in an appropriate position and then to help correct the deformity. The first thing to start off with is we start performing a retrograde nailing of the femur. Of course, the thing to mention is that I have analyzed the deformity. I've made a meticulous plan of where I want to perform osteotomies, what it is going to look like once I've done the osteotomies, and what it will look like once the femoral nail is in. So here is an entry wire, which is a 2.8 millimeter diameter wire, which we put in the distal femur with very much the same way that you would perform any retrograde femoral nailing. We get a perfect lateral of the distal femur, and here you can see the external fixator. You can see here the entry guide wire, the 2.8 millimeter guide wire, and here we are, because I know this is where the nail is going to go. So where we want to put our external fixator pin is outside of the path of the nail, and here is the tip of it to show exactly where I want to insert it, and here it is inserted in the distal femur. We then also put another pin right at the proximal end. This is for two reasons. One is to, once the femur has been divided, to keep the femur very stable, and secondly, allow us to ascertain the rotation so you don't inadvertently rotate the femur when you are nailing it. Meticulous preoperative planning. So I know that the places that I want to perform my osteotomies are in these two places because he has got a multi-apical deformity. And here it is. During the operation, I do an osteotomy of the distal side and of the proximal one. You can actually see my osteotome that has divided the bone here at exactly the level that I want it. You can see the intramedullary reaming wire that's been placed and passed. And look, here it is. We passed the wire through the the distal fragments, the intermediate fragment, and the proximal fragment here as well. Here, then the canal has been reamed, and now we want to put the nail in. But the thing with this nail is that we want it to be in a very specific place in this bone. And here I have utilized a technique called a blocking screw. So the blocking screw, what it does is, and here it is looking at it in the lateral to make sure that it goes through both cortices. And here you can see that the blocking screw here has pushed the nail right over to the lateral side. And I know if I do this, the nail will be in exactly the right place in the distal femur and will correct my deformity and will do what I want it to do. Here we are, and this is at the proximal osteotomy. So the more proximal osteotomy, we pass the nail down, and you can see that up here on the right-hand side of the screen is the lateral side. This is where the greater trochanter is. And what we want to do is that we want to push this nail to go into the medial side to take out the varus and try and valgize that proximal fragment as much as possible. This is now, instead of a screw, I'm using a wire. So this is a thick wire. It's a 2.8 millimeter entry wire that I've used here. And the way that I'm going to use this is a particular technique that I really like using. So you bring the nail up and you hitch it against the wire. Then you really hammer hard so that you get a bend in the wire. It's very important to have a thick wire, because with the thinner wires, with a 1.6 millimeter or a 2 millimeter wire, you can actually break the wire here. And then what you do is, with a T-handle, you can flick the wire around, and that hugs the corner of the nail and allows you to pass the nail so that you can position the tip of the nail in the appropriate place in the femoral canal. Without doing this, you can see, look, this is where the position of the wire is. Without doing this, the tip of the nail will end up a little bit over here, and by being over here, you will not get rid of the proximal varus in the femur. This is the first post-operative image that you can see, and the osteotomies are fresh here. And the reason I get this is that I know the alignment now is good, and I'm happy with the alignment, and the patient is absolutely delighted. Here we are. So this is at a year down the line, when both the osteotomies have healed. You can see the blue line is the mechanical axis of the lower limb, and after we have done the deformity correction, you can see that the mechanical axis very nicely goes now through the center of the knee.